this is fun. The bottom drawer, it's like your least used drawer. The thing on my left is called a manual jet or the bend jet ventilator. These are commonly used for ENT surgery where the person is not intubated and but they're still asleep, so they're not breathing for themselves. And the surgeons, normally the ENT surgeon, will have a particular instrument to go through to either look at the vocal cords or anywhere around the oropharynx, and they might do some biopsies or things like that. But they can't put, they don't want a tubing in the way. Okay? What this does is, when a particular instrument is into the patient, it's a secondary little port. And we will attach a particular attachment. One will go to the patient's side, and the other part will go towards this oxygen delivery device. It's like a garden hose, right? Because this will deliver oxygen, hence the wide cable, which attaches to the oxygen outlet, whether it's on a cylinder or off the wall. And this little device will give you flush of oxygen. Okay. How do you get from here to here? Like I mentioned before, this will go on the wall, connects to here. Check. Little plastic device I've got here connects to the tip of this. Check. Remember, the patient's asleep. They've got a particular, don't quote, I can't remember the actual equipment they use. It's a bit like what do you call those? Those sword swallowers. There's a little sword, okay, yeah, that's going through into the mouth. And on the tip of that is a little connection that goes to this. So on the distal part of their instrument is a hole. And that's pointing towards where the lungs is going to get inflated. So you're above the cords. You're not actually in. Well, you can also be in if you really want to, but most of the time just outside. So we can't tell whether the person's breathing. All we're relying on is the saturation. So it's a shared airway. So when the surgeon, he or she will do their thing, they'll need to make sure the person's satisfactorily anaesthetized. We can't measure this carbon CO2. And once then there's a safety net of what kind of saturation we're happy with, but suitable for a particular patient. And if we reach that point where no, we don't want, we need surgery to stop, we insufflate. It's going to be a flush of air into your oropharynx, and it's directed towards where trachea is going to be. You will see some rise and fall, and you keep doing that. Incremental until you hit another, till you hit a nice saturation of 100 at least, and then the anaesthetist will stop insufflating and the surgery will start. It's called a manual jet. Pro, yeah, you can still ventilate. Cons is it's a flush of oxygen into a space, and depending on your setting here, a bit like when you're pumping your tyre on your car, it's all rushing, isn't it? Rush, rush, rush. Remember I told you about your lungs like a balloon, so when you're inflating it, you're nice and gentle, everything's gentle. Even though you're trying to be gentle, it's still going to come in a rush and cause barrel trauma. And the other thing is we don't know, we can't measure CO2. So we're only depending on one item, which is whether saturation. A person can have a high level of, because the person's not breathing, high level of CO2, can't they? It's like we're trying to hold your breath. And you're only insufflating so many times and you stop. So that's a con. So this is called a manual jet or bend jet ventilator. And the last one here is called a micro tricothyrotomy. Think about it as a surgical airway, where a person who's going to do the procedure, operate, knows what he or she's going to do. It's kind of the very, 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 very last resort. Because this part here is the last one that you're going to try to get an airway. Because if you fail to get that airway, there's nowhere else to deliver safe oxygenation. So if the person's going to use this most of the time, I've never seen this used most of the time, they'll keep the person adequately ventilated, whatever means that is, until a particular operator will do a complete surgical incision. Okay. There's no more bridge to burn if you stop it up using this particular device. Micro means selling this very small hole. Punch a hole, put a little tube in there, and connect. Yes, you can save a life, but if you don't quite get it right, there's different layers in there. I've never done it before. You want again get a person who's going to do a surgical incision and get it right first time around, and get a tracheostomy in there, get the stolid through there, and ventilate. And that will be nearly the completion of our presentation. Normally on the top shelf here is a fibre optic scope, similar scope we use for the bronchoscopy, except the internal and external diameter is a bit thinner. And we also got some disposable kit, and that's what we use if we're going to do a thing called a wave fibre optic. We use similar devices, external devices here, except we're just using another telescope that we're going to use. And this one, and the TV screen, the scope for the CMAC, and also the fibre optic scope, disposable unit and TV screen is kept on that side of the room, closest to PR number 2. Thank you.